Research is solid. 3 verified source bases confirmed. NYU Langone, JACC, Ogedegbe et al., 2015. On ACE inhibitor outcomes in Black patients. BMC Medicine, Brewster et al., 2013. On pharmacogenomics of anti-hypertensive drugs in patients of African ancestry. Health Affairs, Jingzong et al., 2022. On clinical trial underrepresentation. Writing now. You've been taking that medication faithfully, every single day. You set an alarm so you never miss a dose. You changed your diet. You cut back on salt. You go to your checkups. And yet something still feels wrong. Your numbers are not where they should be. Or maybe the numbers look fine on paper, but your body is telling you a different story. You are tired in ways that sleep does not fix. Your head feels heavy. You have that dry cough that your doctor says is just a side effect you have to live with. And somewhere in the back of your mind, you have been wondering whether this medication is actually working the way it is supposed to work for you. Here is what nobody told you. The medication you are taking right now may have been chosen based on research that was not designed with your body in mind. Not because your doctor is careless, not because the medication is bad, but because the entire system that produced the evidence behind that prescription was built on data that consistently, repeatedly, and provably underrepresented people who look like you. And in the specific case of one of the most commonly prescribed drug classes for high blood pressure, the research is no longer just suggesting a difference, it is confirming one. A difference that has been sitting in published studies, in clinical guidelines, and in the recommendations of major medical institutions, while millions of Black patients around the world are still being handed the same prescription that the data says works less well for them, and in some cases, makes things measurably worse. This is exactly the kind of conversation Marcus Webb, Black Health Truth, exists to have. Not to create fear, not to tell you medicine is your enemy, but to give you the same access to the complete scientific picture that you deserve to have every time you walk into a clinic anywhere in the world. By the end of this video, you will understand why certain blood pressure medications have a documented reduced effectiveness in people of African descent, what the genetics behind that difference look like, and most importantly, what questions you need to be asking at your next appointment so that your treatment is built around your actual biology and not a population average that was never designed to include you. Let us start with what we are covering today. We are going to talk about the renin-angiotensin-aldosterone system, which sounds complicated, but I am going to make it very clear and very personal. We are going to talk about cytochrome P450 enzymes, specifically a variant called CYP2D6 that affects how your liver processes roughly 1/4 of all medications in common use, and why the version of that enzyme more common in people of African ancestry changes the picture for a wide range of drugs. We are going to look at what the clinical trial representation numbers actually show, because the statistics are not abstract. They have names, they have consequences, and you need to know them. And then I am going to give you a specific protocol, specific language, a specific set of questions that puts you in the most informed position possible the next time you sit across from a prescribing physician. Start with the blood pressure story, because this is where the data is clearest and the real-world consequences are most immediate. High blood pressure, what doctors call hypertension, affects more than 40% of Black adults in the United States alone, and at rates that are significantly higher across the African diaspora than in other populations globally. This is not disputed. What is less discussed in the average clinical encounter is why the first medication your doctor reaches for may be producing a completely different outcome in your body compared to what the studies originally predicted. There is a hormonal pathway in your body called the renin-angiotensin-aldosterone system. Renin is an enzyme your kidneys release when your blood pressure drops. It sets off a chain reaction that ends with a molecule called angiotensin II, which tightens your blood vessels and raises your pressure back up. Think of it like a thermostat. Renin turns up the heat. Angiotensin II is the heat itself. One of the most widely prescribed classes of blood pressure medication, angiotensin-converting enzyme inhibitors, or ACE inhibitors, works by blocking part of that chain. Drugs like lisinopril, enalapril, and ramipril are all in this family. They interrupt the system that produces angiotensin II. If your hypertension is being driven by an overactive renin-angiotensin system, these drugs can be highly effective. Here is what the research shows about patients of African ancestry. A significant proportion of Black people with hypertension have what is called low renin, high-volume hypertension, meaning the thermostat analogy does not quite apply. The elevated pressure is not primarily being driven by the renin pathway. It is being driven by fluid volume and other mechanisms. When you give someone a medication designed to block a pathway that is not the main driver of their problem, the medication does less, sometimes considerably less. That is not a theory. That is peer-reviewed evidence. A comprehensive, systematic review published in BMC Medicine examined why patients of African ancestry consistently respond better to calcium channel blockers and diuretics than to ACE inhibitors and beta blockers. The review identified multiple biological mechanisms, including genetic variants in the angiotensinogen gene that are more prevalent in people of African descent, which predict how much or how little blood pressure reduction an individual will actually get from ACE inhibitor therapy. In some individuals carrying specific variants, the blood pressure barely moved at all when treated with these medications, not because they were doing anything wrong, because their biology was different from the biology that was used to design the dosing expectations. Let me say that again. Their biology was different, and nobody told them. A landmark study published in the Journal of the American College of Cardiology by researchers at New York University looked at real-world clinical data from over 76,000 patients. They compared cardiovascular outcomes in Black and white patients who were prescribed one of 4 classes of blood pressure medication. The finding was direct. Black patients on ACE inhibitor-based treatment had a statistically significant rate of poorer cardiovascular outcomes compared to Black patients on other drug classes. The difference was not small. It was clinically meaningful. White patients showed no such difference between drug classes. The study authors stated clearly that the results add to a growing consensus among physicians that treatment of hypertension in Black patients should not be initiated with ACE inhibitors. That paper was published in 2015. The British National Institute for Health and Care Excellence, one of the most rigorous clinical guideline bodies in the world, already recommends that people of Black African or Black Caribbean heritage be offered calcium channel blockers first rather than ACE inhibitors. That recommendation exists. It is published. It is available to every prescribing physician on the planet. Now I know what some of you are thinking. If the evidence is that clear, why is my doctor still prescribing this? I am not here to put your doctor in a corner. Most physicians are working from protocols built inside systems that have not fully integrated the population-specific data. They have busy practices, they have time constraints, and they are working from guidelines that, in many countries, still present these medications as interchangeable first-line options without prominently flagging the ancestral context. This is a structural problem, not a personal failure on your doctor's part, but understanding it gives you the ability to walk in with the right question, and that question can change the conversation. The first question to bring to your doctor is this: given the evidence that ACE inhibitors and beta blockers show reduced effectiveness in many patients of African ancestry, have we considered starting with a calcium channel blocker or a thiazide diuretic as first-line treatment for my blood pressure? That single question positions you as an informed patient and invites your physician into a more targeted clinical conversation. This content is educational, not medical advice, and no medication decision should be made without direct consultation with your prescribing physician. But being informed about the evidence is how you ensure that consultation is complete. Now let us go deeper. Because the ACE inhibitor story is the most visible example, but it is not the only one. Inside your liver, there is a family of enzymes called cytochrome P450, or CYP450. These enzymes are your body's chemical processing plant. When a drug enters your bloodstream, the liver uses CYP450 enzymes to break it down, convert it, and eventually clear it from your system. Different people have different versions of these genes, and those differences, which are called polymorphisms, are not randomly distributed across populations. They follow ancestral patterns that have been shaped over thousands of years of human genetic history. One of the most clinically important members of this enzyme family is called CYP2D6. This single enzyme is responsible for metabolizing approximately 25% of all drugs in common clinical use. That includes a wide range of antidepressants, antipsychotics, many pain medications, certain beta blockers, and several cardiovascular drugs. The variant that is particularly relevant to people of African descent is called CYP2D6*17. This variant, which is found at higher frequencies in Bantu-related populations across East and Southern Africa, reduces the metabolic activity of the enzyme. A study published in a peer-reviewed pharmacogenetics journal that genotyped populations in Tanzania, Zimbabwe, and among the Venda people of South Africa found that the CYP2D6*17 allele appeared at frequencies around 20 to 30% in these populations. What does a reduced activity CYP2D6 enzyme mean in practical terms? It means that drugs processed by this enzyme move through your system more slowly than the standard dosing guidelines were designed to account for. Think of it this way. Imagine your liver is a factory with workers on an assembly line. The job is to process the incoming medication and send it where it needs to go. Most dosing guidelines were calibrated for a factory running at a certain speed. Now imagine some of those workers are doing the same job, but at a slower pace. The medication starts to build up on the line. Instead of moving through and clearing efficiently, it accumulates. For some drugs, that means higher levels in the bloodstream than intended, which can produce side effects that should not appear at the prescribed dose. For other drugs, particularly prodrugs that require metabolic activation before they become effective, a slower enzyme means the drug never fully converts to its active form, and the patient experiences a diminished therapeutic effect while thinking the medication simply does not work for them. This is documented. This is not speculation. And yet pharmacogenomic testing, which would identify an individual's specific CYP enzyme profile and allow for truly personalized dosing, is not standard practice in most clinical settings anywhere in the world. Most patients are dosed based on population averages that were derived from studies where the ancestral diversity needed to accurately characterize these enzyme differences simply was not present. If this makes you feel frustrated, that frustration is legitimate. It is grounded in something real. Let me tell you about a man who understood that frustration from the inside. He had been managing his blood pressure for 9 years. He checked his numbers every morning. He took his medication, a combination that included an ACE inhibitor, without fail. He went to his annual checkups, and his doctor told him his numbers were acceptable. He was 54 years old, living in Accra, with a job, a family, and a body that had been working against a treatment plan that was working against him. He never experienced dramatic symptoms, no sudden warning, just one morning when he did not wake up the way he was supposed to. And the people who loved him sat with the particular grief of wondering whether something different could have been done. He sat at every one of those appointments thinking, I am doing everything right. I am following every instruction. Why does it feel like it is not enough? The answer was not in his effort or his discipline. The answer was in the data that had never been built to find him. That story has versions in Lagos, in Kingston, in London, in Atlanta, in Sao Paulo, in Nairobi. The mechanism is the same. The institutional gap is the same. And the knowledge that could change the outcome is available right now. That is why this matters. If you have found this kind of information valuable, this is exactly what Marcus Webb, Black Health Truth, is built to give you. Evidence that speaks directly to your biology and your community. If you want to make sure you do not miss these conversations, subscribe and come back every week. And while you are here, tell me in the comments, what medication have you been taking the longest without anyone explaining why it was chosen for you specifically? That question matters. Now, let us connect this to the larger system that produced both of these problems. Because the CYP enzyme story and the ACE inhibitor story are not isolated mistakes. They are products of the same structural gap. A study published in Health Affairs examined pivotal clinical trials for drugs approved by the United States Food and Drug Administration over a span of years. The researchers calculated what they called a representativeness ratio, comparing the proportion of Black participants in each trial to the proportion of the disease burden that Black patients actually carry in the population. A ratio of 1 would mean fair representation. The median representativeness ratio they found was 0.31, meaning that on average, across the drugs that received approval, Black patients were enrolled at less than 1/3 the rate that their disease burden would require for the data to be meaningful for them. And in cardiovascular disease trials specifically, that ratio fell to 0.19, less than 1/5. That is not a minor footnote. That is the foundation on which dosing guidelines, prescribing recommendations, and clinical protocols are built. When you fill a prescription tonight, the evidence behind that prescription was generated primarily from bodies that are biologically, ancestrally, and genetically different from yours in ways that are now clearly documented to affect drug response. That is not a conspiracy. It is a data gap, a measurable, quantifiable, published data gap. And knowing it exists is the beginning of navigating around it. Now, what can you actually do with all of this? Because information without action is just pressure. And you have had enough pressure. First, if you are currently being managed for high blood pressure, ask your doctor specifically about drug class selection. The question is straightforward. Is my current blood pressure medication a calcium channel blocker or a thiazide-type diuretic? Or am I on an ACE inhibitor or a beta blocker as the primary agent? If it is the latter, and especially if your blood pressure control has been difficult, ask whether the research on drug class response in patients of African ancestry has been considered in your treatment plan. You are not accusing your doctor of negligence. You are bringing peer-reviewed evidence into the room and asking for a conversation. Second, ask about pharmacogenomic testing. Most clinicians know what it is. Some practices already offer it. A simple genetic test can identify your CYP2D6 profile and tell your prescribing physician exactly how quickly or slowly you metabolize drugs in that pathway. That information can be used to adjust dosing for any drug in that category to match your actual biology. If the test is not available where you currently receive care, ask your doctor to refer you to someone who can order it, or ask what information they would need to consider it. The act of asking educates the system. Third, document your responses to medications. Keep a simple log. How did you feel in the first 2 weeks of starting a new medication? Did a cough appear? Did fatigue increase? Did your swelling get worse before it got better? These observations are clinically meaningful, especially in the context of pharmacogenomic variability. They are the signal your body is sending. They become evidence when you write them down and bring them to your next appointment. Think about what that means. You have information about your own body that your doctor can only access through you. Let me bring this together. What we have covered today is not theoretical. Every claim in this video is backed by published, peer-reviewed research from institutions including New York University, BMC Medicine, and the Health Affairs Journal, among others. High blood pressure medication, specifically ACE inhibitors and beta blockers, shows documented reduced effectiveness and, in some studies, worsened cardiovascular outcomes in patients of African descent compared to calcium channel blockers and diuretics. This difference is biologically grounded in the low renin, high-volume physiology more common in Black patients, and in specific genetic variants in the angiotensinogen gene. In parallel, the CYP2D6 enzyme variant, more prevalent in populations of African ancestry, produces slower drug metabolism across approximately 1/4 of all commonly prescribed medications, which affects dosing accuracy for a wide range of drugs in a way that standard prescribing protocols do not account for. Both of these issues exist within a larger context in which Black patients were enrolled at less than 1/3 of the clinically meaningful rate in the trials that built the evidence base now used to treat them. None of this means medicine cannot work for you. It means medicine works better when it is built for you. Your body is not broken. It has not failed to respond. It has been responding to data that was never calibrated to find it. That is not a personal deficit. That is a system gap. And the moment you walk into that appointment with the questions this video gave you, you are no longer waiting for the system to find you. You are finding it. Your challenge for the next 7 days is this. Look at the label on your blood pressure medication if you are taking one. Write down the name. Search whether it is an ACE inhibitor, a beta blocker, a calcium channel blocker, or a thiazide diuretic. If it is one of the first two categories, bring the question to your doctor at your next visit. Ask whether your treatment was chosen with the evidence about drug class response in patients of African ancestry in mind. Notice how your body feels this week. Notice whether the cough is there, whether the fatigue is there, whether your numbers are actually stable or just averaging in a way that looks acceptable on a chart. And ask at your next appointment, have we ever discussed pharmacogenomic testing and how my genetics might affect the way I process this medication? That one question is worth more than a year of silent compliance with a plan that was never designed specifically for you. If what you heard today felt like a conversation that was long overdue, share this video with someone you care about, someone who is managing their blood pressure, someone whose mother or father or spouse is trusting a prescription without knowing the full picture. Subscribe to this channel so you do not miss what comes next. Every week, we bring the same level of evidence and the same direct conversation to topics that matter to this community. Your health deserves a doctor who knows your biology. That conversation starts here.